Hi, this is Dr. Bob Dannenhoffer, Public Health Officer in Douglas County, with another of our Facebook Live events. Tonight is July the 7th, and we'll get started. I have sporting my new balaclava here. We're going to take it down for those people who read lips. I'm also not stuck on the wall like I was last Friday for those of you who watched live, but this will be a higher technical quality tonight. Anyway, so let's start as we always do. Which is to tell you that if you've got questions, please leave them on the chat, and our assistants here will give them to me and we'll be able to answer your questions. But let me start off with what's happening with COVID in the world. Still a very, 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 very active pandemic in the world. We're seeing over 11, probably be 12 million cases by tomorrow throughout the world, lots of over 500,000 deaths. And we're seeing really an incredibly impressive increase in cases in India. And so India, one of the world's largest countries, very densely packed, really hard to socially distance, households which are enormous, and we're concerned that this is spreading so very rapidly in India. India's got a very stratified society with a big difference between the higher income and the lower income people. And the real concern is that this spreads among low income people in India. It's going to be really hard to get under control. They opened up a 10,000 bed COVID space for what they expect to be the number of severe cases. We're also still seeing a very active infection in South America, Brazil, Peru, and Chile especially. Apparently today the president of Brazil, Bolsonaro, was confirmed to be infected with COVID. So that's a real concern, and we wonder how that's going to change Brazil's view of the pandemic here. We're also seeing in the world that there's some places that continue to do very well. We think the number of cases in Europe is very low. They've opened up some travel and opened up some international travel, and Australia and Brazil continue to do well. Although the Australian example is interesting. Australia had this down to just a very few cases a day, and now they've had a recent outbreak in an area, and they've needed to close down again to get this under control. And I think this is what we'll see, is that places get this under control, they're going to need to have little intensifications of effort to get it back under control, and then this is how we'll go. In the U.S., unfortunately, there's no places that are under reasonably good control, and we're still having a big outbreak. We're seeing especially an enormous number of cases in Texas, Florida, California, and Arizona. And so it's a really active pandemic in those areas. We're seeing, especially in Texas and Arizona, that their ICU capacity is hitting full. There's already a number of ICUs that are totally full, and they're moving patients around. And that starts to get worried because most of this outbreak in the U.S. at this time is young people. Well, young people don't use a lot of ICU beds. The concern, though, is that if you looked at the way the pandemic progressed in Seattle, at the very early time of it, we think there were a lot of young people who had the disease. They weren't very sick, but because there was no testing around and you couldn't test them, these young people kind of circulated the virus. They didn't get very sick. You didn't really know very much until these young people then spread it to older people and then went to work at places like nursing homes. And then 2 or 3 weeks later, as the people in nursing homes got infected, you started to see the really high death rate. So my concern is that although it's mostly young people in Texas and Arizona and California, that those young people are going to bring it home to the older people, or go to work in a nursing home and bring it to the older people. In a week or 2 or 3 from now, we'll start to see a real increase in the sickness in older people. And so that's a worry. Oregon continues to do reasonably well. We still have the 6th lowest attack rate in the country, although the number of cases we're seeing in Oregon is really pretty astounding. We were less than 100 for a long time. The last 2 days we fell under 300, and we felt it was a good day. In Douglas County, we're still doing pretty well. We're at 54 cases, although we've added more cases in the last 10 days than any 10 days before. So we're really now starting to see more and more of these little clusters. Many of these clusters are associated with out-of-state travel, either Douglas County residents who've moved out of state or out-of-state people who've come to Douglas County and brought the disease with them. And it's now just not California, Washington. It's California, Washington, Utah, Nevada, Alaska. It's sort of all over this disease is coming from. And that's because the disease is so much more prevalent in these other areas. So somebody tried to ask me, but let's put it in the same thing. So assuming Douglas County, we have 54 cases and no deaths. Assuming that we had the same rate as the rest of Oregon, we would have 200 cases and 10 deaths. If we had the rate of the U.S. overall, we'd have in Douglas County 1,000 cases and 40 deaths. And if we had the rate of disease that they had in New York, we'd have almost 2,000 cases and 170 deaths. So the fact that we haven't seen any deaths in Douglas County and relatively few hospitalizations, I think only 6 or 7 total, it really hasn't impacted us very much, but there's no reason to think that we are somehow better or smarter and couldn't, for example, have a higher rate. Even when I look at Oregon, we've had a very low rate. We've had the 4th lowest attack rate in Oregon, and I know we're pretty smart, but we're not that smart. If you compare us to like Umatilla or Union County or Hood River County or Yamhill County, they have a much, much, much higher rate of disease and more deaths. So I think still in Douglas County, I think we're both good, but I think we're also very lucky, and we'll see what goes on. So we'll get some questions here. A couple other things we wanted to point out today. One is, we had a question along the way, is asthma a risk factor? And there was some sense it may or may not be a risk factor. The longer study came out today and suggested if it was a risk factor, it was only a minor risk factor. Okay, so Veronica says, so if you could pass COVID through droplets, why can't you have a test from your mouth instead of your nose? That's a very good question, and actually this has been come up because one of the problems we're going to have when we're going to test people a lot is that if you get that deep in your nose test, there are not going to be a lot of people who are willing to do that every day, and people are perfectly willing to spit every day. So there's been a real move towards moving to a saliva-based test rather than a nasally based test. Early on, was thought that the nasopharyngeal swabs were probably the most accurate and you should do those. There is some recent data out, though, about saliva-based tests, which suggests that using a special technique for saliva to get rid of all the juice, that these tests actually can be pretty accurate. And that would be great, because you'll remember 3 months ago what I said I wanted for Christmas this year was an easy saliva-based test where you could spit in the tube and take a shower, and then when you got done, you could look to see if you were infected. And I think we may be making progress with that. That would also be tremendously effective for something like what we call pool testing. So imagine you have the football team there, and you want to see if anybody on your football team is infected. The way you'd have to do that now is you have to do these nasopharyngeal swabs. They take, at the fastest, 15 minutes each to do, so by the time you tested the whole team, it would take either multiple machines or 10 hours to get it done. With the pooled saliva-based test, presumably could everybody spit in the bucket, and if the whole bucket was negative, you could then say that everybody on the team was negative and be good. If it was positive, then you could test everybody on the team and find out who was positive. So saliva is incredibly promising. I just hope it works out. Fortunately, what we've seen in this epidemic is that these things come out and they look like they're going to be great, and then 2 weeks later it gets debunked as not good, so we'll see. So Rick says, why did you stop reporting recovered? It seems important to know how many are currently ill. And yes, you're exactly right, Rick. So in the past, we used the number of recovered as being those number of people who were 10 days from a positive test, or those people who were without symptoms. And that was a good definition for recovered. However, throughout the country, the definition of recovered changed to be a certain date from the onset of symptoms. And so that when the definitions of things change midstream, it makes it really hard to know, because if we use the new definition of recovered, our number of recovered would either, depending upon how you did it, either decrease or stay exactly the same along the way. So what we did instead is we now do the number of people in isolation. The number of people in isolation is your best approximation of those who are currently ill. It may overestimate a little bit. because some of the people in isolation are either asymptomatic or mildly symptomatic. But since that symptomatic stuff changes every day, it's really hard to know. But if you really want to know how many people are currently ill, look at the number that we publish every day, which is the number currently in isolation. I think today was 15 or 16. 15. So Virginia says, could you explain monoclonal antibody therapy, and you think it has promise in treating COVID? So monoclonal antibodies are antibodies that are produced and attack a certain thing in the body. And we think monoclonal antibodies actually could work. So what those would be you'd get an antibody against the spike protein, you'd reproduce that antibody, and then you would give people a big dose of that antibody. So it's really, it's pretty promising. We've not yet used it. We've not yet had a great monoclonal antibody for a disease. There's a drug called polyvimuzab, which is used for RSV, which is one of these monoclonal antibodies. It has not been particularly effective, but this is one of the areas of research on this. And this would be great because it would then be early in the disease. You get a dose of monoclonal antibody, and with this dose of monoclonal antibody, it should help prevent the disease from spreading. So I think that's a promising area. So when we looked at how this is going to end, how will this end? We might get a vaccine, and there's now a fourth one that's promising. We might get a vaccine, enough people get vaccinated, and when we would be done. We might get a preventive medicine like a monoclonal antibody, which you could either use as a preventive that the high-risk people would get once a month, or you would get as soon as you got sick. That might work. You could get a really good antiviral drug, sort of like an antibiotic works for bacteria. An antiviral drug would work for viruses. And we have some great antiviral drugs out there now. For example, the antiviral drugs that treat HIV are really very effective. The antiviral drugs that treat herpes are really quite effective. And so we could come up with a really effective antiviral drug. Convalescent plasma may work, although, the early data from convalescent plasma suggests it's effective, but not that effective. And then there may be something which is totally unheard of. We didn't think steroids would work, and then we found Decadron might be helpful. So there could be something else that we don't know. Or we may never find anything that really works, and this disease may just go through the population enough until enough people develop antibodies. I think that would be pretty disappointing because that means a lot of disease and a lot of deaths. So Dale Ann says, have they figured out the R naught for this thing yet? No. Because the R naught means the basic reproductive number, that in a population that doesn't do anything, how fast this would spread. The problem is we've not had anybody just let this spread and then see what would happen, because the concern was that it would be bad. So one of the things that you can look is the R-T, and there's actually a website that I look at every day called RT Now, and it gives what the basic reproductive number is for this virus in the different states at the different points, and there's a little graph about what the RT now is. So R naught is, if you did nothing, it's probably above 3, because actually in some states that are doing things, it's above 3. So it's probably above 3 as the R naught, but the RT is really the thing to look at. And so in an area when their RT is less than 1, so it means that for every one case, less than one new person gets infected, then the disease is going to go down in prevalence. So in New York, the RT is well less than 1. But in some places, like in Texas and California, the RT is well above 1, and that's worrisome. I think in the end, they'll be able to figure out what the R naught is. I bet you it's going to be, my guess, 3.4. So Patty says, I heard on the news today that there's a vaccine almost ready. Is that true? No, it's definitely not true. So the story is there a vaccine ready? So yeah, there's a vaccine that they're ready to give for a phase 3 trial. That is, they're ready to inject it in people. But what they don't know is that when you inject it in a lot of people, will it work for young people? Will it work for old people? Will it produce antibodies? Will it have side effects? And will it actually prevent the disease? And so yes, they're making vaccine, and that it's ready is maybe one question, but the answer is there an safe and effective vaccine ready? And the answer is we don't know yet, because we don't know if any of these vaccines are going to be safe and effective. So Susan says, should local medical offices be following protocols versus redistancing and mask use? Yes, everybody should be using the things for distancing and mask use. Now, there are sometimes you can't distance in the medical office. I cannot look in a kid's ears from 6 feet away. And so I was in the clinic today and I looked at some kids. But at the times that I wasn't doing something specific like that, I was indeed distancing. And during the time I was using a face covering, and we had the patients using a face covering, we'd really recommend that. Now, we don't think in Douglas County so far there's been a lot of spread in doctors' offices, but as the disease gets more likely, it's more likely to happen. So please, 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 everybody should be using a face covering and distancing as best they can. So if I don't have a PCP, where can I get tested? Well, first, I would recommend that you get a PCP. There's some new docs coming to town, both at Evergreen and at Aviva. I actually have my appointment with one of the residents next week. But if you don't have a doctor, you can get an order for a test by calling Aviva at 541-459-3788. So if someone travels outside of Oregon, is it suggested to be in isolation or quarantine for 14 days? Well, if you could, absolutely. So if you could be in quarantine for 14 days, that would be great. Now, many of us can't, right? Got work to do, things to do, and you can't do that. But yeah, to be safest, it would always be safest if you go to a high-risk area. So again, think of this, so that, again, there's 54 cases in Douglas County. But if you go to a place like Arizona, a similar sized place would have as much as 1,500 cases, 30 times as many cases. So your chance of getting this in Arizona would be considerably higher. And so you really need to be careful. So yes, if you could quarantine after your return, that would always be best. Some people can't. If you can't, then I would strongly encourage you to avoid big groups and to socially distance and to self-monitor. So if you start having symptoms, don't go to work for 3 or 4 days to see what this is going to be. Stay home. So Leslie says, what are the risk factors for COVID? It always seems to change. Yeah, and it does seem to change a little bit. Remember, this is a relatively new disease. And the way we look at risk factors is we look at people who had the disease, those who had a worse outcome or a better outcome. I think we've always agreed that diabetes seemed to be a risk factor, chronic kidney disease, neurodegenerative disease, autoimmune disease always seem to be a risk factor, and they still seem to be. We aren't quite sure about asthma, we aren't quite sure about pregnancy. They may be slight risk factors. And then there are some other things that are probably not risk factors. So for example, type O blood is a risk factor, is a negative risk factor. Actually, you're better if you have type O blood. The new CDC has one about risk factors for COVID. I've been a little critical of CDC's graphics and whatever. This one is great because it goes through all the conditions, it goes through the evidence, and if you want to see exactly where it's from, you can push a button and it'll show you exactly where it's from. Now, some of us care about all disease, but most people care about the diseases they have, right? So if you've got diabetes or whatever, you would care about that. Now, it's very interesting. Type 2 diabetes seems to be a risk factor. So type 2 diabetes, adult diabetes seems to be a big risk factor. Type 1 diabetes, which is childhood diabetes, seems to be much less of a risk factor. So Janice says, do you think we will close down again? I certainly hope not. There are a bunch of places in the country that have. So, Texas started up, was doing a lot of elective surgeries. They've stopped doing those. They've closed down bars. I really, really, really hope we don't have to close down again. There's a story on the radio this morning about people closing down and how demoralizing it was. So here was a bar, and they had this bar, and the bar had to close down, and people sort of struggled along. They lived on savings or whatever. And then in May, they started opening up again. Thought this was great. By the 10th of June, they got going. They just got going, and then they had to close down again. And so now at this point, they don't have any savings. They don't have any PPP money. And people are really, really concerned about that. So I hope we in Oregon do not have to close down again. So how are we going to not close down again? Do all the other things. Socially distance, wear a face covering, stay home if you're sick, wash your hands, really all the basic, simple stuff. Now, I will tell you over the last week, I think the use of masks has really improved. So thank you for that. So, why are some employers not publicizing confirmed cases so we can be aware? Is there a place to find this information? And yes, there is a place to find it. Now, Oregon published the information when it gets to be a certain size. I think 5 cases in a place that has more than 30 employees. So in a small place, they don't publicize those, or in a place that has just a few cases. Not exactly clear, actually, though, that if you have one case in a firm, you really need to do that. We've really not had. We don't think we've had any spread at work. Now, I don't know if that's true, but when we look around at these cases, we think almost all the spread we've gotten is either through home contact or through travel. So we don't think so. So Virginia says, I've heard there's a recent mutation of the virus making it more transmissible but less lethal. Is that true? I don't think so. So there is a thing. So on the surface protein or the spike protein in space 614, it switched from a D to a G on the nucleotide. And when that happens, it changes the amino acid that's in the protein. And when it changes the amino acid in the protein, it changes the spike protein from being a sort of a fragile spike protein that would break to a more sturdy spike protein that's more likely to enter the cell. I think people suggest that this is considerably more infectious, and that's why when people talk about the R naught, as the virus changes, the R naught may change. The people at Los Alamos think this is 10 times more contagious, but not more lethal. So not less lethal, but not more lethal either. So can you still get a test without insurance? Gabriel asks, yes. And as part of the CARES Act, people were not supposed to get any bills for these tests. We think that's still probably true. We do know that if you go through our drive-through, Quest has promised us that they would not send anybody a bill, and so far they've been good to that. So Virginia says, I see several different types of masks as the recommended face covering. Yeah, I think the recommended face coverings are going to be either a shield that goes underneath your chin. I was going to bring mine today, but those work great. And for people who get claustrophobic in masks, which they do, or just hate a mask, actually a face shield is a perfectly reasonable thing to use. In terms of masks, you can use a purchased paper mask. Those purchased paper masks work pretty well. You can use a home-built cloth mask or balaclava. This is mine. The home ones are supposed to have 3 layers of fabric, so my wife puts the fabric in it for me, but any of those would be reasonably good. Now, if you watched my Facebook Live from Friday, I did one with bubbles, and you can see that the force of your expiration is so much less using even the flimsiest face coverings that any face covering you wear will be okay. So someone says, I know someone who was diagnosed with pleurisy. They wouldn't test for COVID. Why not? And I don't know. I can't explain other people's suggestions. We think anybody with a respiratory illness should have it. So pleurisy is an inflammation of the lung lining that gives you pain on deep inspiration. I've not had it, but I hear it can be pretty darn miserable. One of the symptoms of COVID can be pain with deep inspiration. So it's probably not COVID, but I don't think there's any way to know without doing a test. So yeah, I would recommend a test. So Veronica says, do antibodies go away quickly with COVID? We don't know. There are a couple of studies out there that have looked at antibodies sequentially in people, and what they found is that they go away pretty quickly. Now, the problem, unfortunately, is that even though antibodies go away, they may be able to come back if challenged again with the virus. So what happens is when you get an infection, you have this big outpouring of antibodies that then goes down. But then if you get challenged again with the virus, they come up again. And that may be the case with COVID. So although the antibodies may go down, they may be able to be revived with what's called the amnestic response. We don't know about that yet. To do that, you'd have to challenge somebody who is already infected with the virus again, and people are really nervous to do that because especially if you had a bad time of the first time, they're worried that you could have a bad time of it again. So we don't know. We do not think that the antibodies are going to last as they do with a disease like measles or a disease like rubella. Those antibodies are pretty persistent. These do seem to go away quickly. They did a study up at Providence where they looked at antibody levels of people and then looked 2 weeks later and 2 weeks later. And most people had a fairly precipitous fall in antibodies. So they may go away quickly. And that's why the WHO has been a little bit concerned about saying that if you have antibodies, you're good to go, because we're not sure yet. So what's the definition of a case? So a definition of a case so there's 3 kinds of cases. One is a suspect case, which nobody other than we hear about. So a suspect case is somebody who has symptoms suggestive of COVID, but doesn't have any tests to suggest it. Now, in many other diseases, suspect cases get counted as cases. So again, I used norovirus, which is our second largest source of outbreaks. So that if you had a party and the next day everybody's vomiting, 34 people vomit, you don't necessarily get 34 tests. You probably test 3 or 4 people in the group, and then consider that everybody was there who had the same symptoms, probably had norovirus, and you say this was an outbreak of 34. With COVID, so we look at suspect cases, but nobody ever sees that number. We're only counting confirmed cases with COVID as people who have a PCR test. The PCR tests are very sophisticated tests that are really, except for a couple of brands, very specific, meaning that if it's positive, you almost certainly have the virus there. And then there's this group in the middle called presumptive cases. These are people who were directly in contact with somebody who's a case, has all the symptoms, but has not yet had a positive test. The state lumps together presumptive and confirmed tests. We break them apart, and that's sometimes a confusion, but we do that. Or a presumptive test is that you've got the symptoms and have a positive antigen test, but not one of the super specific PCR tests. So that's that. So your question, though, is if one tests positive 2 different times, is it counted as 2 cases or one? It's counted as 1 case. So it's counted as 1 case. So we have a lot of people who had the disease and get retested for work or other things, and they're positive and positive, positive, positive. We have one person who's been positive for 2 months now. We don't think they're contagious after 9 or 10 days, but they continue to show positive tests. We think of it like bugs on the windshield. So you're driving along, there's bugs out there, they're clearly live bugs. You drive through them, they get stuck on your windshield and die. And so when you look later and look at the car, there are dead bugs on the windshield. And they clearly are bugs, and they're clearly dead. They're clearly no longer able to bite you. But you wouldn't say there are live bugs on your windshield. They're all pretty dead. We think when we swab these people 2 or 3 or 4 weeks later, and they still have a positive test, that this is the equivalent of dead bugs on the windshield. No longer contagious, but yes, they're having it. But we only count cases once. So some of these 50 people, sometimes people will have more than 1 test, but we only count it once. Yeah, so Alan says, what's the current information as to permanent damage done to people after they are recovered, such as lung damage? And that's why we were a little cautious about using the word recovered, because we do know that there are people who, even though they're better, still have lots of symptoms, especially of shortness of breath, and especially still abnormal CT scans. The other thing that we found this week is they looked at a bunch of people who had the disease, positive tests, and were asymptomatic. Totally never had cough, never had fever, never had shortness of breath or anything else, and they did a CT scan. They had lung damage. So almost everybody who they screened had some lung damage. And we don't know how long this is going to last or what's going to go on. It's a little worrisome that some of our earliest cases still are pretty short of breath. It's a long time to be short of breath. And so we're not exactly sure what's going to go on. Now, some of our early cases feel totally great, but we haven't had like the really sophisticated studies like lung perfusion studies or whatever to know. But this is a big concern. when you look at some of these CT scans, they are gross. I mean, the lung should look like a beautiful sponge, so that if you cut through a natural sea sponge, what you see in there is you see nice lacy architecture, no inflammation. You see a relatively even, sometimes a little bit of difference in size, but really a nice look to it. These lungs look terrible. There's areas where there's this stuff called ground glass opacity. So rather than looking through a clear glass, it looks like a fogged up glass. And then there's these funny patterns called crazy paving, which looks like paver stones that have sort of glommed together. So we don't know about the long-term damage, but we're worried looking at these terrible CT scans that these people may have troubles. So we are told to wear masks to protect others, and why doesn't a mask protect me? So what masks mostly do is to protect others, and the reason for that is that droplets just, as they come through your mouth, the velocity of the air is slowed so much that droplets don't spread very far. So again, 2 very nice Facebook videos, Mythbusters 1 and Mythbusters 2, you could look out. But if you want to see something a little more scientific, Florida International University put one out where they have lasers and stuff, and it shows that a mask really slows down the spread from your face, so that's great. Now in terms of, so masks clearly protect others, and that's why early on, the Surgeon General wasn't that big on masks, because we didn't know at the time about pre-symptomatic spread. But now that we know that people are actually much more contagious the day before they have symptoms, and I don't know if I'll have symptoms tomorrow, I need to wear my mask to protect you. Now the question is, does the mask protect me? Well, the only masks that definitely protect me would be an N95 mask. And N95 masks are hard to come by. They're really uncomfortable to wear. Nobody's going to want to wear one of those all day. And those are there to protect the wearer. So the N95 masks, I've used N95 masks when we deal with a tuberculosis patient. And they're very tight-fitting masks, actually. Kristen here works with us in doing it. And they're so tight that the way we test to see how tight they are is put you in this hood, spray in some either bitter or sweet-smelling stuff. And the mask is so tight-fitting that you can't smell the bitter or sweet-smelling stuff. In fact, if you can smell it, then you flunk the test. So these are pretty tight masks. So yes, N95 mask would protect you. When you get down to surgical masks and homemade masks, they protect a lot less well. The other trouble is with a mask is that the reason they may not protect you as well is you do have a tendency to touch your face. So unless you really are trained not to touch your face, you do touch your face, and that may increase it. The data on how much the mask protects you is sort of up in the air. There was a study last week that suggested it might protect you a little bit. Other studies suggest it won't. So it may protect you a little bit, but it really does protect others. Yeah, so Dale says, is the radiographic evidence you mentioned found in young people too? And the answer is yes. So in China, the way they did this early on is the way they diagnosed people was they did CT scans on anybody who had any symptoms. And what they found was that young people with really mild symptoms did have this change in the lungs, even though they didn't really have very many other symptoms. So yes, it's that CT scan. It's not usually found on a regular one, but a CT scan. So Cindy says, is it true that this virus acts on the brain with high fever, hallucinations, and nightmares? Yes. So we are starting to see some people, especially who are really sick, have symptoms of what we call encephalitis. That's inflammation of the brain, and that can cause hallucinations, nightmares, loss of memory, and behavioral changes. So this is a nasty virus. So will testing positive affect organ donation down the road? We do not think so, because we do not think that that once you're over this, once you test negative, we don't think the virus is in a persistent chronic state. Now, there are some viruses that are. So, for example, if you get the chickenpox virus, that virus always lives in your body and your nerve roots and can come out later as zoster or shingles. Or, for example, if you get a herpes infection early on, it can come back later as a cold sore. We do not think coronaviruses live in a dormant state in the body, so it shouldn't affect organ donation. But I don't know the answer to that. I'll look that up and see. So Linda says, can you tell us about the baseball team that was here and had 8 confirmed cases? Yeah, are the teams in this town being treated? Well, again, there's no treatment for COVID, but the question is, are the teams in town being tested? I think we looked at exposures, and that's still under investigation, whether any of the teams had exposure. So, for example, if you look at baseball, baseball is actually one of the safest sports, other than the batter and the catcher, who tend to be about 4.5 feet away. There's really not a lot of other close contact between players. And for most batting events, you're up there 2.5 or 3 minutes. So remember, ours is less than 6 feet for more than 15 minutes. We think in baseball that rarely, if ever, happens. So right now we don't know of any contacts, but that's something we're looking at. So someone says, Zach says, I hear zinc and vitamin D3 will build your immune system to fight COVID. What is my opinion? So zinc is a great thing. Vitamin D3 is a great thing. And we know that people who have higher levels of vitamin D have better immune systems. But people who have higher levels of vitamin D are also tend to be more outside more and be more active. So, if you take somebody who is working in the garden every day and they're out in the sun every day and doing those things, they're going to have a higher vitamin D level than somebody who's a couch potato and sits inside. But if you take the couch potato and sits inside and gives them vitamin D3, it's not like you make their immune system like the farmer. So clearly, it's better to have a higher vitamin D level, but giving vitamin D to bring that level up has not really been shown to make a big difference. Similarly, people eat a wide-based diet that has lots of fruits and vegetables and whatever, tend to have higher zinc levels. But it's not necessary that if you give somebody who has a terrible diet zinc, that their immune system will get better. So we don't know if the higher zinc levels and high vitamin D3 levels are because you're just living a better life, or giving people who don't do those things vitamin D or zinc will improve it. We don't know the answer. We don't think either of those is dangerous, so that if people want to take zinc or vitamin D, that would be great. So Bernadette says, and I knew I was going to get this question, is COVID now airborne? So we've always worried that there was some airborne spread. To hear about these huge super spreader events, the choir practice in Washington, the lawyer who spread it a lot, it was really hard to imagine that somehow there wasn't some airborne spread. I think what came to light in the last week is over 200 epidemiologists wrote a letter to the WHO, said, hey, get on board. We think that airborne is at least part of the spread. And even those who have looked at it think airborne is probably at least some of the spread. Still, we think the majority of these are droplets, because when we look, most of the cases we have are better explained by droplets than airborne. Right? So if it was mostly airborne, we know that maybe some cases, but if it was mostly airborne, you'd expect to see a lot of cases, for example, in a movie theater where one person had and gave it to a bunch of people. We don't really see that. So there's probably some that's airborne, but it's droplets. Now, what's the difference between airborne? What's the difference? Well, the difference, if it's airborne, masks still work really well to stop those aerosols that do it. So even more reason to wear a mask. But what it does change is it does change in people who are going to be very close to patients, like in the operating room or in the ICU, that they may need to use a higher level of protection. So that would be the difference. It would also be a difference in that you'd then be more concerned about air handling systems like air conditioning and whatever, because it's airborne. That would suggest that it could be picked up by a heating or ventilation system, and if you didn't have good filtration, it could be circulated again. So Linda says, when visiting a casino, it is remarkable all the things they're doing and not doing. Are they required to report? And I don't know what you're asking to report. So businesses are supposed to follow some rules. There's nobody really, there's no, like, as I said, there's no real mask police. OSHA is enforcing some workplace rules. Oregon Health Authority may be enforcing some other rules, but really not. I think one of the ways to do it is if you go to the manager and say, hey, look, I'm here at the casino to spend my money, and I'm not really interested in spending money if people are not going to be safe here. I think that's going to be our best way to get people to do it. Yeah, Brandy says, what's the recommendation for anybody exposed last weekend with the out-of-town team? I imagine it's the out-of-town baseball team. Well, if you think you were exposed, and that is you were within 6 feet for more than 15 minutes of one of those players, first I would say shame on you. You should have done that. But if you were, then let us know. Because when we look back at context, people are usually pretty good at recalling them, but maybe not. Like I always think back, if I was exposed and I had to report what I did 5 days ago, it may be hard for me to remember, oh yeah, I did see so-and-so at the such and such, and we had this 20-minute conversation about baseball or something. So if you think you're exposed, give us a call tomorrow, 464, at our hotline number, which I'll get for you in just a moment. So are tests taking a long time to get back? Yes. I know somebody's waiting 8 days. That's not surprising anymore. You'll remember that the test initially took a long time, a week or 10 days. We then got them down to the point where we were getting most of the results, in just a few days. And they're started now to get longer again. The reason for that is that with the huge outbreaks in Texas, Arizona, and California, that the tests go to usually national laboratories, and the national laboratories are getting actually pummeled with the number of tests from those areas. So yes, tests are taking longer. We're working through Quest. We have most of them back within 4 days, but we're still waiting 8 days on some of them. So yeah, it's taking 8 days. Waiting 8 days is really too long. Really, in our country, we should be at a point where you can get the test result back the next morning. I think waiting 8 days is hard because what are you going to do? You're going to quarantine for 8. I guess you're going to quarantine for 8 days until you know the results. But that level of uncertainty just causes so much turmoil. We really, as a country, have got to do better. Okay, so the number for the hotline is 464-6550, and somebody will be able to answer, go through the question, let you know if you're a contact, and then if you are, then the recommendation would be quarantine and test. So Carol says, do KN95 masks provide the wearer protection? So N95 masks are the U.S. style of masks. These, the 95 means that they prevent 95% of tiny particles from passing the mask. They're very high-level mask, and they work great. We also have those hoods that we wear when we do this, which are the equivalent of N99 masks. Now the Chinese made a variation of N95 masks, which they called KN95. And the specifications for the KN95 masks, for real true KN95 masks, are almost identical to the United States N95 masks. So during the time there was a shortage, the FDA approved KN95 masks to be used in the place of N95 masks, and they still do. The problem was there were so many counterfeits, and there were so many companies that came in with pieces of junk KN95. They said they were KN95 masks, but they weren't. And so we've got a bunch of them here, and they're so unreliable now that the recommendation is, unless you bought them and you're sure that they're from one of the few still approved manufacturers, the rest you should consider to be not acceptable, and to use them only as you would a face covering or a surgical mask. It's unfortunate because a lot of people pay $2 or $3 or $5 for these KN95 masks that are worth about 10 cents. So there's been a lot of gouging with that. And there's been a lot of gouging through the whole deal. You know, we look at the cost of gowns and the cost of other masks. The cost is really crazy, and really suggests that there's been some price gouging. So a couple more things I want to talk about. One is I'm on the Governor's Healthy Schools Reopening Council. We met for seemingly forever today. It does look like there's going to be a plan to open K-6 in the fall. A little less clear what's going to happen with junior high and high school, but it does look like K-6 is going to open. And the good news is that in countries that have opened up K-6, they've not really seen a lot of cases from them. Now, there have been a number of cases in the last few weeks in kids. And in fact, we have our first case in somebody under 20. So we are starting to see younger people with the disease. And the younger people with the disease is a worry because, again, the young people are the ones who tend to do a lot, go a lot of places, go to bars and stuff like that. We're worried that those younger people are going to bring it home to their parents or grandparents, and then we're going to start to see illness. So I really ask the younger people to be cautious about what you do. But then we're also starting to see more cases in kids, but almost all those cases, the disease was brought in by the parents. So one of the parents or one of the teachers had the disease, and then the kids tested positive. We don't think the kids are necessarily spreading it a lot. Another thing that came out new was about Decadron. So remember, Decadron is the steroid, brand name Decadron, generic name dexamethasone, that was shown in the Oxford study to help people who were quite sick with it. It turns out that when you look better at the data, that it did not help people early on in the disease, but it did help them once they started to get really sick. In fact, it may have hurt them actually early on. And that goes along with this thing that we've talked about, that early on, the disease looks like an infectious pneumonia disease. And for many people, it's an infectious pneumonia and they get over it. But for a small group of people, it seems to really cause lots of troubles with really low oxygen levels, clotting, and other kind of things. And apparently during that period, the Decadron helps. So it's every time we look at this, it is a little more confusing. Okay, well, it's at 6:48, and I hear we're out of questions. All right, again, this is Dr. Bob Dannenhoffer, Public Health Officer of Douglas County. Just a few things I'd ask. One is, please follow the advice. This has not changed over the time. Socially distance. Stay home if you're sick. Wash your hands. The relatively newer advice is to wear a face covering when you're out. And my advice I've given from the very beginning is be kind. And I'm incredibly impressed at how kind people in Douglas County have been to us. You know, other places in the state say that their contact tracers are getting yelled at or people won't answer the phone, and we've not seen that here. So thank you for that. Again, Dr. Bob Dannenhoffer, Public Health Officer in Douglas County. Thanks.